Welcome to our Caribbean and African Targeted Health Improvement Program, CATHIP Health Hour. The Caribbean and African Health Network, CAN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating, and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members, and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses, and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell, and many more. Not forgotten to include within our health hours the many societal, cultural, religious, and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences, and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@can.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.
Good morning, everybody, and welcome to another Health Hour. Thank you for joining us this morning, and it's lovely to see you. We've got a really interesting topic for you today, and it's wonderful to see all of you. We have gathered your feedback, and I know that lots of people want to have topics about women. So we've got a fantastic speaker today. He's well known to us because he's been here before. He has presented to us, and his name is Dr. Edi-Osagie. My name's Ngozi. I'm a paediatrician who works in Manchester, and I'm also the medical lead for the Caribbean African Health Network. So really looking forward to listening to this. We're going to cover the topics of endometriosis and fibroids. And for those of you that are Black women, you know that this is a topic that if you personally are not affected, you've got family friends, you've got colleagues, Black colleagues, who fibroids is just a really big problem for Black women. Endometriosis is not very well known about, but I know that it also affects lots of Black women as well. And so that's why we're bringing it today, because it takes a very long time when you have the symptoms before you're actually diagnosed. So I hope that by listening today and tuning in, that you'll be able to take something away from this. The session will last for about half an hour with Dr. Edi-Osagie presenting, and then after that, we'll give an opportunity for the many questions that I know you have. So Dr. Edi-Osagie, welcome.
Thank you very much. Thank you for that great introduction. And it's great to be back on Can Health Hour. I've been here before, as you mentioned, and it's always fantastic to come back here. And thank you so much. I can see that so many people have joined us on a Saturday morning when you could be doing a lot of other interesting things. So it's great to have you here. I'll start by sharing my screen. I hope everyone can see that. So I am a gynecologist, and I'm based here in Manchester, and my NHS practice is at St. Mary's Hospital in Manchester, and I undertake private practice in the Manchester and Cheshire area as well. My specialist interests are in reproductive medicine and surgery, and I've been doing this for, I would say, maybe the last 30 odd years. It's something I have a passion for. And I think it's really relevant that we are talking about endometriosis and fibroids today, because I don't know if everyone knows that this month of March is Endometriosis Awareness Month. And it's such a common condition affecting 1 in 10 women, and we know so little about it, and there's so little awareness about it that anything we can do to increase that awareness will be absolutely wonderful. And the two conditions we're focusing on today, endometriosis and fibroids, are linked by a hormone called estrogen. And some people who are aware of women's health will know that this is a hormone that has been called the elixir of life. And as we do in CAN, I think it's really, really important that before we delve into those conditions, we go back to the basics and explain what this is and how it comes about and how it impacts on women. So essentially, I'd like to start by explaining how the female body functions, and then we'll go on to talk about those conditions. The other really important reason why it's pertinent that we're discussing this now is that we've just had the release of very new endometriosis guidelines, which are put on here for people to see. And the web address for the guidelines are also on there. So for people who want to have a look themselves, it's very, very comprehensive, and it covers a lot of what we need to know about this condition and how to manage it. And I would recommend it for anybody who wants to have more in-depth knowledge of the condition. So, I mean, when we look at the female, we have to divide a woman's life into various stages. And you can see from this very busy slide that there are important things that happen to a woman during fetal life before she's born. And there's an important prepubertal stage, a pubertal stage, the reproductive years, and then the menopause. And all of these impact on how a woman's body functions. One of the things I always like to explain is that all the eggs women have in life are placed in their wombs when they are still developing as little fetuses in their mother's wombs. So women do not form any new eggs in life. Unlike men who carry on forming sperm all through life, this does not occur in women. And that is a major difference of how men's and women's fertility differs. So we reckon that at the time women are born, they're probably, at about 20 weeks of gestation, women probably have about 7 million eggs in their ovaries, but by the time they are born, that number has decreased to about 2 million. And all through the prepubertal years, up to maybe about the age of, on average, 12 years, there's not much that happens. Those eggs just keep depleting in number, and there's not much that happens hormone-wise, apart from just physical growth of a female. And then at the age of puberty, which on average is maybe about 13 years, there are profound hormonal changes that take place, and a girl starts to have periods. And those periods carry on cyclically every month. And during those periods, there are depletion of eggs. So we reckon that maybe at the beginning of that pubertal period, each woman has about 500,000 eggs left in her ovaries. And every month she selects a cohort from that number and depletes them, ovulates one, the rest die away. And all those are the eggs that are available to her to use during the reproductive years. And the menopause, as you know, it happens when all the eggs have been depleted from their ovaries. And the key hormone that makes all of those happen is estrogen. And estrogen is controlled by a very precise mechanism where the brain secretes a hormone that tells the ovaries to develop eggs and to release estrogen. And the estrogen works on the lining of the womb to prepare it for pregnancy. When the egg is ovulated, if it fertilizes and implants, pregnancy occurs. But if it doesn't fertilize and implant, then that egg complex just regresses or dies away, and a period happens. And this happens classically every month throughout the reproductive years. And I'm explaining this because this is important to the two conditions that we're going to discuss today. So what we consider normal for women is a menstrual bleed duration of between 2 and 7 days. We class those as normal. So anything below or anything above might be an indication that there might be a problem. And also what we consider normal for women's cycles is any duration of cycle. And by cycle, a menstrual cycle will mean the interval between one period and another period, any duration between 21 and 35 days, as long as there isn't more than a week's variation between one cycle to another. So those we will consider as normal. And what typically happens during a menstrual period is the endometrium is shed because pregnancy doesn't happen. And what we expect is that blood from the endometrium passes through the cervix into the vagina and is shed as menstrual blood. And that's what we expect to typically happen. But we now know that that's not the full story. We now know that every single woman, without exception, also allows a small amount of that blood that is shed to pass through the tubes into the pelvis. And some of this blood can carry cells from the lining of the womb. And I'll come back to this. So essentially, this is just a jocular slide that just illustrates exactly what goes on during the menstrual cycle. The brain releasing hormone, telling the ovaries to develop eggs, the eggs growing, releasing estrogens, stimulates the lining of the womb. The eggs get ovulated, and if it fertilizes, it implants and leads to pregnancy. If it doesn't lead to pregnancy, the lining of the womb is shed, and this happens over and over and over again. And as I said, this is really important for the development of both fibroids and endometriosis, as I will explain as we go along. And those two conditions we class as estrogen-dependent conditions. And that's because you need a background of estrogen production from the ovaries for those conditions to happen. So if we start with endometriosis, what is endometriosis? We still know very little about endometriosis, but we do know enough about it now to understand exactly what it is. In the old days, we used to think that endometriosis was just a pelvic disease that caused a few lesions in women's pelvis. But we now know that endometriosis is more of a systemic chronic inflammatory condition where the cells that normally line the lining of the womb that are shed during periods find their way into the woman's pelvis and start to grow. And that growth stimulates a lot of inflammation, and that causes pain, that causes adhesions, that causes tissues to stick together, that releases a lot of nauseous substances that can impact on fertility. And that essentially is endometriosis. And we know that it's a common condition. It affects about 1 in 10 women generally. But in women who have subfertility, we find endometriosis in about 40%. So 4 in 10 of those women will have endometriosis. And this picture just shows you some of the common sites where we find endometriosis, typically on the lining of the walls of the pelvis, but also on virtually any pelvic organ, and even further away outside the pelvis. So what we now understand is that endometriosis can affect virtually any tissue within the woman's body. And these two pictures illustrate what endometriosis does. So the picture to the left is a normal pelvis, and here you can see the normal uterus. You can see the fallopian tubes, you can see the ovaries, you can see how clean that pelvis is, you can differentiate all the organs. While the picture on the right demonstrates a pelvis that has been affected by endometriosis. And you can see how it looks very angry. There are a lot of these brownish, reddish lesions of endometriosis. The tissues are stuck together. The tube on one side appears to be blocked, stuck to the ovary. So this is the problem we have with endometriosis. And that just illustrates the problems it causes. So if you consider that endometriosis affects 1 in 10 women and you extrapolate that figure worldwide, you can see that endometriosis is a very common condition. And there are estimates that up to 176 million women are affected worldwide. And one of the problems is that endometriosis is not diagnosed early. On average, it takes about 8 years for women who suffer with endometriosis to have a diagnosis made. The other issue is that not everybody with endometriosis has symptoms. So about a quarter of women who have endometriosis don't have any symptoms at all. A further issue is that endometriosis can be a factor in women struggling to conceive. So all of these things make it really, really important to know a bit more about endometriosis. So what problems does endometriosis give rise to? The predominant problem is pain, menstrual pain, pain before periods, pain during sex, pain when moving the bowel, pain when passing urine. So what we generally say is that any woman whose life is interrupted by pain, so if for any reason you cannot get on with your work life, your school life, you're missing school, you're missing work during periods or just before periods, that's not normal. Anybody who's so affected, you consider whether they have endometriosis. So it can cause pain, painful sex, and sometimes to the point where sex life is completely disrupted. It can give rise to heavy and painful menstrual periods. There are other things associated with endometriosis that are not commonly known, and one of those is fatigue. So a lot of women with endometriosis suffer with extreme fatigue, where you just feel completely drained for no reason at all. And all of these obviously impact on a woman's quality of life, and we've already mentioned its impact on fertility. So one of the things that has really, really helped us in managing endometriosis better now is we're beginning to understand that we used to think endometriosis was just this homogeneous condition, as I said, that just affected the pelvis, but we now know that there are different types of endometriosis, and by finding out exactly what type of endometriosis a woman is experiencing, that helps us to manage her better. So we now know that endometriosis can be peritoneal, where it just develops on the lining of the pelvis or on the surface of the pelvic organs, and that is the most common type of endometriosis. Some women have what we call cystic endometriosis, and that's endometriosis that forms cysts in the ovaries, and this can grow to large sizes, and I'll show you a picture of one of these shortly. Another type of endometriosis is the deeply infiltrating disease, where endometriosis can invade deep tissues and cause significant problems in those tissues. And endometriosis can develop in the womb and lead to a condition called adenomyosis. And this is a condition that is commonly confused with fibroids because the presentations are not too dissimilar. And on ultrasound or even MRI, it can be sometimes difficult to differentiate them. And we can have endometriosis in virtually any tissue in the body. We found endometriosis in the lungs, in the brain, in the upper abdomen, and that's what's referred to as extragenital endometriosis. So these are just pictures of endometriotic lesions affecting the pelvis, the peritoneum of the pelvis, which I said is the most common variety. This is the posterior pelvis, and this is the anterior pelvis. And you can see all of these nasty looking lesions. This is what endometriosis causes. So this causes a lot of inflammation, a lot of pain. So the way to think about it is when a woman is having her period normally, all of these lesions will also be bleeding, and that blood within the pelvis can give rise to significant pain. So this is endometriosis developing within the ovaries. We call this endometrioma. And as you can see, these ovaries can grow to large sizes. And sadly, sometimes they can rupture and lead to significant acute abdomens that will need urgent surgery. Then we have the deeply infiltrating endometriosis. So this is endometriosis that forms dense tissues in organs. So this is, for example, affecting the bladder. So this is what it looks like on the outside, what it looks like on the inside. And when we operate on it, this is a kind of area of the bladder that is affected that we have to remove. So virtually any tissue in the body can be affected. This one is going into the bowel. But the good thing about all of these is that they are remediable. So these are examples of extragenital lesions. This is endometriosis in the belly button, in an episiotomy scar, in a cesarean section scar. And this is endometriosis that affected the lungs in a lady before treatment and after treatment. So you can see we can treat endometriosis. And one of the things that we now do much better than we did in the past was diagnosis of endometriosis. So we do not rely now on just laparoscopy, which is an operation in hospital to diagnose endometriosis. By taking a good history, undertaking a good physical examination, and doing an ultrasound, in the vast majority of women with endometriosis, we can make a diagnosis and commence treatments. And how do we treat endometriosis? There are medical options, so we can use painkillers, we can use things to minimize pain, we can use hormones, because these are estrogen-dependent conditions. Any hormone that antagonizes the estrogens that cause the inflammation will be helpful for endometriosis. So things like the common pill, the combined pill, the mini pill, the progesterone implants, or the Mirena coil can help in managing endometriosis. And sometimes we can shut the ovaries down. And there are some newer drugs that are coming along now that are also helpful in managing endometriosis. The one thing I'll say about medical management of endometriosis is that it can help us to manage pain, but it doesn't help with the subfertility that some women present with. And so surgery really is the established way of dealing with endometriosis. And the most common forms of endometriosis, including the peritoneal, the ovarian, and the deeply infiltrating, we have established surgical ways of dealing with them. And I always get asked about this. So I always like to just explain what we do at the time of surgery. For anybody who is a bit queasy, this is a time to go put your kettle on and make some coffee. All these are available on YouTube. So if you want, you can Google it yourself and get more educated. So these are endometriotic lesions on the pelvis, affecting both the pelvic wall and the ovaries. And this is how we remove the endometriosis. So we do a complete excision of the pelvic wall lining. And in that way, we get rid of all the endometriotic lesions. And similarly, this is the ovary. So this lady had a big endometriotic cyst in her ovary, and we do the same thing. We cut into the ovary, we drain the ovary, we remove the endometriotic cyst completely, and then repair the ovary, as you'll see us do in a minute. So the reason I like to show this when I do these talks is just to reassure women that endometriosis is a condition that we do not know a lot about, but we know enough about it to be able to treat it effectively. And there are good, effective surgical ways of treating endometriosis. So you can see in this pelvis, we have gotten rid of all the endometriosis this woman has on her pelvic wall and in her ovaries. And we know from studies we've done that by doing this, we're going to relieve her of pain and we're going to improve her fertility. So there are good treatments for endometriosis. Okay, I know we're running out of time, so I'm just going to move on to fibroids very briefly. So what are fibroids? Fibroids are, the way to think about fibroids, we define fibroids as benign tumors that grow within the womb of women. We all know what benign breast lumps are. And the way I try to explain fibroids is that people should consider fibroids as benign uterine lumps. You know, so they are benign, they're not cancerous, and they just lead to clumps of tissue within the uterus. So this is just an illustration of the way fibroids are. They are very common. Fibroids probably affect up to 50% of women at some stage in life. A lot of them do not cause any problems. And sometimes we just pick them up when we're examining women or scanning them for other reasons. Where they cause problems, predominantly they cause problems to do with the menstrual cycle. So this illustrates the type of fibroid. And the reason I'm showing this is a lot of the time I get asked by women, so are fibroids in my womb or outside my womb? And I try to explain fibroids are always inside the womb, but they might be at different locations in the womb. So we have fibroids that are predominantly in the cavity of the womb, like this one we call submucosal. And then we have other fibroids that are predominantly towards the outside of the womb, and this we call the subserosal. And then in between those, we have the fibroids that are just bang in the middle of the womb, and those we call intramural. The problems fibroids cause and their implications depend a lot on their size, on their numbers, and on their location. So as a general rule, the bigger fibroids are, and the closer they are to the cavity of the womb, the more problems they cause. So as I said, although we do not know how common fibroids are, we think maybe up to 40 to 50% of women will have fibroids at some stage. Fibroids affect all races, but they tend to be more common in women of Afro-Caribbean origin. And the older women are, the more likely they'll have fibroids. I came across this and I thought this was a really, really good illustration of the problems that fibroids cause. So they cause heavier than normal menstrual bleeding, heavier periods. They cause stronger than normal menstrual pains, periods that last longer than a week, anemia due to heavy bleeding. They can cause irregular bleeding, bleeding in between periods. They can give rise to pelvic pressure or pain. They can affect the bowel and lead to constipation. They can cause painful bowel motions. Depending on where they are located, they can give rise to pain in the low back. And if they're big enough, they can cause a distension of the abdomen. They can cause pain during sex. They can cause bloating of the abdomen. And obviously, they can impact on fertility. And they can increase the risk of miscarriage, depending on where they are located and their size. And again, they can cause problems with passing urine. And just to highlight some of the issues they can cause with fertility, they can interfere with sex. They can cause problems with sex, and they can interfere with the passage of the sperm from the vagina through the womb into the tube to achieve fertilization of an egg. And when we do IVF, they can get in the way of us being able to reach the ovaries to collect eggs for IVF. They can interfere with implantation of a fertilized egg into the lining of the womb. And if the fibroids are close to the lining of the womb, they can increase the risk of miscarriage. And as I said, the closer they are, the more submucosal they are, the greater the impact that they have. We don't know if for certain what size fibroid we will consider as being significant, but generally we use a cutoff of 5 centimeters. So if a fibroid is larger than 5 centimeters, then we feel that at that stage, they might warrant some sort of intervention. So how do we diagnose fibroids? Generally, history and examination. So the history we've talked about, history of menstrual dysfunction, especially if there's some abdominal swelling. The examination usually is confirmatory of this. Ultrasound is the mainstay of diagnosis of fibroids. And where there's any confusion, we sometimes will do MRI scans, and that would give us more information. So I'll put conservative in terms of treating fibroids. Not all fibroids require treatment. There's a whole host of fibroids that we find incidentally in women who have no symptoms at all and that are not big enough for us to offer any intervention. And in such situations, we don't do anything. We can just monitor them, and that's sufficient in situations like that. In certain situations, we apply medical therapy. Again, because they are estrogen dependent, everything that we've talked about for use with endometriosis can also be useful for fibroids, but they do not help fertility. So where fertility is an issue, surgery is the hallmark of our treatment methods. And when we do surgery for fibroids, there are 2 main types of surgery we do. So we'll either do a myomectomy, which is removal of the fibroid itself with conservation of the womb, or we'll do a hysterectomy, which is removal of the womb. And for the myomectomy, for any of these, there are different approaches we use: keyhole surgery, open abdominal surgery, or hysteroscopic surgery. And again, because I get asked this question, particularly by women who are concerned about losing their wombs, I like to show this picture, which shows how we can very, very effectively manage fibroids, conserve the womb, conserve fertility, and improve women's quality of life and fertility. There are many women who are concerned that fibroid operations will increase their risk of losing the womb. And can I just state categorically that in my 30 years of gynecological practice, I haven't seen one womb that has been removed as a complication of a fibroid operation. So I hope that will reassure some of our women. We know it's a complication that can happen, but what I always tell people is any surgeon who is trained and who is surgically equipped to undertake a safe fibroid operation is unlikely to have a complication where it needs removal of the womb. So I think what people need to do is to do their research and find people who have expertise in delivering this treatment for women. And it is very, very safe. And I would recommend that people seek help rather than suffer in silence. So you can see for an operation like this, we remove the fibroids and we take care to repair the womb, because the repair of the womb is really, really critical to the function of the womb afterwards. So for fertility reasons, we take meticulous care to repair the womb, to restore its function after an operation. And these operations are very, very, very successful. And after we have repaired the womb, of course, the other question we get asked is, what do we do about the fibroids? I've just got a little clip at the end showing you what we do about the fibroids, how we get rid of the fibroids. We have some clever tools that help us to chop the fibroids up into little bits, and that's how we get them out of the abdomen and pelvis. So fibroid operations are very safe. Women should not suffer in silence. So to finish, just to reiterate that endometriosis is very common. It's a systemic inflammatory disease, and it can affect virtually any tissue in the body, but the most common areas are in the pelvis, in the peritoneum, in the ovaries. We have very effective ways of diagnosing it, and we have very effective ways of treating it. And similarly for fibroids, fibroids are common. They probably affect up to 50% of women of Afro-Caribbean heritage, and their most predominant symptoms are menstrual dysfunction, and we have very effective ways of, again, diagnosing and treating fibroids. Thank you very much. I think I'll stop there, and I'm sure we'll have questions and contributions to the discussion. Thank you.
Thank you. Okay, as expected, there are quite a number of questions. This has been a fantastic talk. No bias at all. But it has generated lots and lots of questions. If you have particular questions that you might be concerned about asking publicly, if you send the questions to me privately, and I'll ask them on your behalf. So one of the first questions I'm going to ask is about the hysterectomy. So whilst you've said that the fibroid operation in itself didn't lead to hysterectomy. We know that many women have said that we have been offered hysterectomies to treat our fibroids, and that, you know, is something of concern. So can you just address this issue of the hysterectomy and fibroids? Thank you.
Yeah, absolutely. As I said in my presentation, hysterectomy is a surgical treatment option for fibroids, just as myomectomy is. But what we generally do is for women who want to preserve their fertility, or even for women who want to be able to carry on having periods, retain their uteruses, we offer a myomectomy where we remove the fibroids from the womb and conserve the womb. But once they get to the stage where they do not need to preserve their uterus or where they do not need future fertility, then a hysterectomy becomes an option. But the woman has a choice in that. Generally, your gynecologist should discuss both options with you and come to an agreement about what's best for you in your situation. What I find, sadly, is not every gynecologist is technically able to undertake a myomectomy safely. And so in situations where people cannot do the myomectomy procedure, they default to offering a hysterectomy. So for any woman out there, a hysterectomy is not the only surgical option you've got available. You can have a myomectomy. So if you get offered a hysterectomy and think that that's not the right operation for you, ask your GP to refer you to somebody else, seek a second opinion, and have a dialogue with that person, and you should be able to get a myomectomy done.
Thank you. There's another question about age of onset. So people are asking, I'm 17. I have very, very heavy periods. Is it likely I have fibroids?
That's a good question. The first thing I'll say is heavy periods do not equate to fibroids and do not equate to endometriosis. There are some women who have heavy periods and that's just them. That's constitutional. What I'll say is, if you have heavy periods that are of concern to you, then seek some advice. Go see somebody so that they can examine you, they can scan you, and they'll be able to tell you whether you got fibroids or not. We know that endometriosis can occur at any age from when estrogens start to become available. We found endometriosis in girls below the age of menarche, before 13 years. So they can occur early. It's unlikely that fibroids will start early in somebody at that age, but they can again occur once estrogens become available. But the important thing is, if you're concerned by the amount of menstrual bleeding you're experiencing, go see somebody, have an examination, have a scan, and they'll tell you what's going on.
There are a number of questions about size of fibroids, operations, and whether they will return. So someone's had a myomectomy 4 years ago. They were quite young when they had it. I've now been told that there's been advised to come off a depot injection. So because they've been advised to come off this depot injection, what is there to stop them from the fibroid from growing? And do fibroids commonly return after you've had an operation? So if you now put yourself through an operation and you're worried that they will return, what's the point in having the operation?
That's a good question. Okay, the first thing I'll say is what I started with by explaining that both fibroids and endometriosis are what we call estrogen-dependent conditions. So for any woman, as long as your ovaries are still producing estrogen, so meaning as long as you're within the reproductive age group, any of those conditions can develop. So both endometriosis and fibroids, even if we operate on them and remove them now, as long as you're still having periods, you can develop new fibroids, you can develop new endometriosis. The point of having them treated is to relieve yourself of the symptoms that they cause, whether it's pain, whether it's heavy periods, whether it's abdominal swelling. So they relieve those conditions. And we know, as I said from my presentation, that if we put you on some hormonal preparations, the combined pill, the progesterone-only pill, or we suppress your ovaries, we can reduce the risk of these conditions coming back. but there is no cure for them. And what I say, for anybody who's predisposed, there is a chance that they can come back. But if they come back, you can have another operation to remove them.
Okay. In terms of when you say that there is that if you're predisposed to them, there's quite a number of questions. I'm going to group them all together about diet, lifestyle, natural ways of preventing endometriosis and fibroids. So are there any diet or lifestyle choices or natural remedies to prevent you from getting endometriosis or fibroids, or that once you've got them, that you can use alternatives to hormones and surgery to help yourself out?
Yeah, we get asked those questions a lot. And the simple answer is unfortunately no. There are no lifestyle or dietary measures that can prevent the onset of those conditions. There are some lifestyle and dietary measures that can help to manage the symptoms you get from them and to reduce the amount they impact on you. But in terms of them developing in the first place, there's no diet or lifestyle that would prevent them completely.
Because they're to do with estrogens, there is no sort of estrogenic foods that might make them worse?
This is an interesting point, because fibroids are commoner in Afro-Caribbean women, and one of the things that we have found over the years is that there are some plants or some vegetables that contain what we call phytoestrogens. So they're like estrogenic substances that are found in these vegetables. A typical example is yams. So women who eat yams tend to get a small amount of phytoestrogens. And we think that maybe that's why menopausal symptoms are not as severe, not as impacting on women from an African background compared to women from a Caribbean background. We don't have any evidence that those things will impact on the growth of fibroids or endometriosis. Well, it's possible to think that they could, and it's possible to think that they could worsen the symptoms, but we don't have any of that evidence.
Okay. Someone said they've had a scan and the scan shows endometriosis and not endometriosis. Are they the same thing? And if not, what's the difference?
Okay, there are two different things. Endometriosis is what I've just described to you in this presentation. There's another condition called endometritis that is just an inflammation of the lining of the womb. That cannot be seen on scan. That's something that you make a diagnosis from after you do a biopsy of the lining of the womb. So it's a totally different condition. So there's no confusion on scan between endometriosis and endometritis, because they just cannot, one cannot be detected on scan, the other can.
Someone's asked about pedunculated fibroids. What is that? Someone's been told I have a pedunculated fibroid.
A pedunculated fibroid just describes the position of the fibroid. It just means that the fibroid is on the outside of your womb and just connected to your womb by a little stalk. It is still a fibroid, and it can still cause all the problems that fibroids cause. And it is amenable to all the treatments that we have described.
It sounds like this one seems to be relatively easy to treat. When you say a stalk, you just clip the stalk. Is that making it sound too simple, or is?
Well, relatively at surgery, it's not as involved as ones that are deeper. Okay, as I said, the deeper it goes into the womb, the harder it is to treat. So yes, in a way.
Okay. A GP has advised me to have the Mirena coil to treat my fibroids. Is that helpful?
Well, the Mirena, if the fibroid is not interfering with the lining of the womb, the Mirena coil can help to reduce heavy bleeding, can help to reduce painful bleeding, but it will not impact on the growth of the fibroid in any way. But it can help to reduce heavy bleeding, yes.
Now this is someone's asked me a question, and it might make sense to you, doesn't make sense to me. It says, is UFE effective?
UFE stands for uterine fibroid embolization.
Okay.
So it's just embolization of fibroids. Yes, it is effective, and it's another treatment option for fibroids. I didn't have time to go into all of the treatment options, but we advise embolization in women who have completed their families and for whom fertility is not an issue anymore. So it is an alternative to hysterectomy, if you like. So I wouldn't recommend embolization for any woman who still has plans to get pregnant and have children in future.
There are a number of questions about bleeding and endometriosis and fibroids. So there are a few women who've sent me private messages, and there's some public that says that they've been bleeding a lot. They can have periods that last 20 days. One of them said that they had the Mirena, but this hasn't helped. And the gynecologist has said that the only thing that they can have now is a hysterectomy. So some have said hysterectomy, but some have said we're stressed out because of the amount of bleeding they're having. Some have anemia. What's just some feedback for the issue with bleeding and fibroids? Yeah,
sadly, bleeding is the most common problem that fibroids cause, and they can cause heavy bleeding, they can cause irregular bleeding, they can cause anemia. There's some people who have repeated blood transfusion because of anemia from fibroids. So it is a well-recognized problem with fibroids. But it is amenable to all the treatments I've discussed. Again, for any woman who's suffering like that, I would say you need to just seek out somebody who understands how to manage fibroids and who will manage them for you. And usually in every NHS hospital, there will be gynecologists who will have a good experience of managing fibroids.
Now, I know this talk was to do with endometriosis and fibroids, but there are quite a number of questions also relating to fertility and fibroids and endometriosis. So the question that they have quite a number of fibroids, and another person said they have endometriosis. They're not in a position to start a family at the moment. So what's the latest treatments, the latest time in terms of age that the NHS will offer you fertility treatment?
The whole fertility treatment thing is I think that's a massive topic, and maybe at some point we'll come back and address that. Now, depending on people have heard about postcode lottery when it comes to fertility treatment. Simple fertility treatment, like maybe going on Clomid, is available to everybody in every NHS hospital, in every CCG. But there are some CCGs or GP practices that will only fund one cycle of IVF, some will fund 2, and some will fund 3. And generally, people are able to access IVF up to the age of 42 years as a general guide, but it varies massively across the country. So I always say, just ask your GP about what your local CCG funds.
Okay. There are a number of questions about the size of fibroids and the symptoms that those cause. So a number of people have sent me messages to say that they don't have pain, but they just have a really big stomach because of the size of the fibroids. Are there any alternatives to invasive surgery that can try and shrink them so that they don't have to go through surgery? One of them has sent a message that it's so embarrassing because of the size that she doesn't like to show her stomach. Yeah. What are the alternatives for having treatment to the fibroids?
Yeah, unfortunately, we get asked this a lot. Fibroids are a mass, and unfortunately, the only way you can remove a mass is to surgically remove it. There are things that we can use to temporize as short-term measures to try and reduce size, reduce discomfort. So we can use hormones to shut the ovaries down for up to 6 months, and that can sometimes make the fibroids go a bit smaller. Or uterine embolization can sometimes reduce the size of certain fibroids. But ultimately, surgery is the definitive treatment of any big fibroid.
I've got lots of fibroids. I've been diagnosed with endometriosis and multiple fibroids. What would you say would be a treatment for that? Because you've got both things. Is it better to go on the combined pill first, or is it better to do surgery first?
Every circumstance is different, and I would say you need to see a gynecologist who will examine you, know exactly what the situation is. Sometimes we treat fibroids first, other times we treat endometriosis first. It just depends on what the situation is and what the stage of both of those conditions are.
Are polyps a type of fibroid, or is that something different?
It's different. So polyps are a different type of benign lump that can grow within the lining of the womb. So they are different from fibroids, yeah.
Okay. Are the treatments the same and the symptoms the same?
Polyps can cause heavy bleeding. They can cause irregular bleeding. They can cause painful periods. And the treatments for polyps are different. Polyps are generally treated by keyhole surgery, where we put in a camera through the neck of the womb into the womb to remove the polyp. Some fibroids can be treated that way, fibroids that are within the cavity of the womb as well.
Okay. Someone's asked about degeneration. They said, do fibroids degenerate?
Yeah.
I suppose that's a yes or no answer, but I think I'll just try and expatiate for this person. What does that mean? And what are the options for treatment if they do degenerate? Yeah,
fibroids degenerate. There are different types of degeneration fibroids can undergo. Sometimes they degenerate, they just get soft. Sometimes they degenerate, they get an infusion of blood into them. Degeneration essentially just means the fibroid is undergoing a change because of a change in its blood supply. And most degenerations will not cause any problems, but there are some degenerations that can give rise to severe pain. So there's something called red degeneration that fibroids undergo, particularly in pregnancy, that can give rise to severe pain. And so women with fibroids in pregnancy can undergo that degeneration, and that will cause pain for which they will require expert treatment. But generally, fibroid degenerations are not a problem, and they can be treated with the measures that we've already discussed.
Okay, this is one of the videos. I've seen this video and I've seen these WhatsApp messages that fibroids are more prevalent in Black women because we've had permed hair, and that the chemicals in these things that we do our hair with have caused fibroids. How true is that?
There is absolutely no basis for that. We think that fibroids are more common in Black people because of just a genetic predisposition.
And so I suppose because more of us perm our hair, somebody's made a link and said it's because of that, isn't it?
Yeah. There's no evidence.
So ladies, for those of you that want to continue to perm, whatever weave, it has no connection to fibroids. A lady's put a message that they've got 2 fibroids of 3 centimeters each. I'm not sure of whether that's big or small, but does it impact, does the size of the fibroid impact your ability to have a baby? Is it size, position? What are the things that you need to consider as a gynecologist when you see someone with fibroids who's trying to get pregnant as well?
Yeah, the size of the fibroids can impact, but more importantly is the position of the fibroids. So if they're 3 centimeters and they're on the outside of the womb, they'll have very minimal impact. But if they're 3 centimeters and they're the inside wall of the womb, then they can have quite significant impact. So again, this is where it's always best to work with your gynecologist, who would be able to explain your scan reports and explain the implications of the fibroids and how to manage them.
Someone's asking, is there a Fibroids Awareness Day?
Maybe Can should have one.
Maybe we should have one, because I host these every week, and this is one that has generated one of the most questions regarding fibroids and fertility as well. Someone said that they have 2 small fibroids, and their periods are really regular and last 4 to 5 days. But that's this month, after their period has ended, they continue to spot, and they wonder whether this is related to the fibroids, or was it something that they should go and see their GP about?
I'll say something they need to see their GP about. They'll need to be examined, because fibroids are not the only thing that can cause spotting. And it's important to find out why the spotting is occurring and to manage it appropriately.
Is it possible to still get pregnant when you've got fibroids?
Absolutely. There are lots of women with fibroids who get pregnant, and fibroids will not stop you getting pregnant, and fibroids will not always cause a miscarriage.
And if you do, is there an option to remove them if you have a cesarean section? Can they do 2 for the price of 1? The baby out and the fibroid out?
Yeah, As much as that is tempting, we avoid it because of the severe bleeding that's associated with fibroid operations. So we don't do them at the cesarean section.
Okay. And also the ladies asked whether it's going to affect the physical appearance of the baby. I'm a neonatologist, so I go to deliveries of lots of women who have fibroids and the babies are perfect. So
Absolutely.
Don't worry about that. What happens to fibroids and endometriosis when you start to go through the menopause stage?
That's a really good question. The vast majority of them will get smaller and stop causing problems, but we still get women who get problems with fibroids and endometriosis in the menopausal stage of life. And so what I'll say is anybody who has problems at that stage, just seek some help. But the vast majority of fibroids and endometriosis will get smaller and cause less problems.
Okay. In terms of endometriosis, you've said that there's so many different ways in which it presents. And that means that there's a problem in terms of diagnosis.
Yeah.
So if someone's here today who's having lots and lots of having pain during their periods and they still haven't been diagnosed with endometriosis, is it anything more than just pain? Are there any other symptoms that they should be thinking about that they need to just get their GP to consider the diagnosis of endometriosis?
What we say is any pain that is out of the ordinary. So if you're having painful periods that stop you from going about your normal business, stop you from going to school, stop you from going to work, that's not normal. And that could be endometriosis or fibroids. If you're getting pain in the week before your period starts, that builds up to the period, that is very, very suggestive of endometriosis. If you have painful sex, that's very suggestive of endometriosis. Okay. And the other thing that a lot of women with endometriosis complain about is increased problems with their bowel, with their urine, and with abdominal bloating in the week leading up to their periods. So any woman who's suffering with those symptoms should consider that endometriosis might be the cause of them and seek some help.
Once you've had a myomectomy, how long does it take to heal? So the lady who's had a myomectomy 11 weeks ago and still has pain and numbness in the abdomen, is that normal? And they've been told before the operation that it would probably take about 4 to 6 weeks. And the second part of this question is, when is it safe to get pregnant once you've had a myomectomy?
We generally tell women that it takes about 3 months for a myomectomy to heal, and they should not try to conceive within those 3 months. But in terms of the numbness, if you have a myomectomy by an abdominal cut, that numbness is going to remain for much longer. It could take a year or even 2 years for that numbness to go away. So, but the pain generally will settle down with the passage of time. At about 3 months, most women will stop feeling pain.
Okay. So there's someone asking a question on behalf of her friend. She said that her friend has fibroids and is pregnant. She said she never gets any problems with the fibroids unless she's pregnant. She doesn't want to get rid of the fibroids because she doesn't want any intervention, I presume. Would that cause problems for her? Do you always have to take the fibroids out when you have fibroids?
Not necessarily, not necessarily. As I said, the type of degeneration called red degeneration is most common during pregnancy. And for some women, it can be a source of profound pain. And some women will need admission for weeks and weeks just to manage that. So if that is happening, then that might be a reason why she should consider removing the fibroids. But if she's able to cope with some mild to moderate discomfort from the fibroids, and she gets pregnant and it doesn't interfere with the rest of the pregnancy, then there's no reason she can just carry on that way.
Okay. If you've had your ovaries your womb removed, but you've got cysts remaining in your abdomen, is that related to gynecological problems?
It depends on what you mean by cysts. You can have adhesions. There are different things that will cause cysts in the abdomen that might not be gynecological. So again, this is where you need to be seeing somebody medical who will be able to sit you down and explain to you exactly what your scan is showing.
Okay. I suppose this question is related to a question about when it's safe to get pregnant. So someone said, what's the safest time to have IVF after you've had the myomectomy?
Again, we just recommend that you shouldn't try and get pregnant for 3 months. So after 3 months after a myomectomy, there's no reason why you can't start IVF.
Okay. This is not related to fibroids or endometriosis, but I suppose since you're a gynecologist, someone's asking on behalf of her daughter who had her first period in November and hasn't had a period since. Is that normal? Yeah,
for the first year or two after periods start, periods can be quite irregular, sometimes profoundly irregular. Again, it's not a problem.
There's a question here about what's the best way to remove fibroids. But I suppose what we've been saying over this last hour is that it really depends on, I'm not an expert, but I think I'm what I've learned from this hour is that it depends on the size and where they are, but I'll leave you to expatiate a bit more.
Absolutely, there's no best way. So it depends on what your presentation is, and it depends on what your expectations are. So we can remove fibroids by keyhole surgery through the abdomen. We can remove fibroids by keyhole surgery through the womb. We can remove surgery by open surgery. So there's really no best way. It just depends on what your needs are.
I have tried to group the questions, but I think some of the questions wanted to be there really specific. So there's someone who said they've got a fibroid that's the size of an apple. Is this something to worry about? And can it reduce naturally, or does it have to be removed surgically?
I'll answer the last question first. I mean, fibroids do not grow smaller. They might not grow very fast, but they don't get smaller. And we don't necessarily remove any fibroid we find. As I said during my presentation, it depends on what they're causing. So if you've got a fibroid the size of an apple and it's not causing you any problems and you're quite happy to carry on the way you are, then you don't need to have it removed.
Okay. Someone's heard, we talked a bit about alternative treatments, but they have heard that there are Chinese remedies such as acupuncture that can help with reducing the size of fibroids.
I'll knock that on his head. There is no alternative treatment that can help with reducing the size of your fibroids. There are some women who will get some sort of symptomatic relief from acupuncture just to help them manage maybe some of the external symptoms like pain, but there is no alternative therapy that will reduce the size of fibroids.
Okay. This is one, I suppose, because you're a gynecologist, we will have questions that are unrelated to fibroids and endometriosis. But this is a question that says, I've had my ovaries removed in July, but I've had a CT colonoscopy that shows that the ovary is still there with a complex cyst. Is this possible?
Well, if you have a scan that has shown it, then it is possible. Again, what I'll say is you need for such a specific situation, you need to be seeing a specialist to go through what the scan shows, but it is possible, yes.
Okay. Is it possible? I think this is another question that I think is you'll understand the context. Is it possible to have ovarian remnant syndrome?
Yes, it is possible. Ovarian remnant syndrome, similar to what the other question was, is somebody who's had part of the ovary removed, but has a small part of the ovary left behind, and that small part of the ovary that's left behind continues to function.
You can see we've had loads of questions and loads of interaction. Someone's asking, do you know of any research that is being undertaken just specifically on fibroids so that they can contribute to?
There are loads of research going on fibroids all the time. We are not doing any one specifically at the moment in Manchester, but there are loads of research going on all the time. There is none that comes to my mind just now, but it's something that I can look into.
Okay. Someone's asking for a link for the endometriosis guidelines, and I know that the Caribbean African Health Net will be able to supply that. They've also asked, I think, because perhaps this is someone who's said that they have asked they've been to see somebody who said because of the number of fibroids that the only treatment is hysterectomy, and you've said, find a gynecologist. They feel they found you. Is there any way that they can see you?
I can leave my website address and email address with Can. So hopefully Can provide that to anybody who wants a second opinion.
If you're over 60, can you get fibroids?
Not for the first time, but if you had fibroids during your reproductive years, then those fibroids can still cause you problems even though you're over 60.
Okay. I think you've dealt with this, but just in case, because it's only just come up, it's advice about prevention of fibroids.
Unfortunately, we do not have any ways of preventing fibroids from growing. What you can do is that if they grow, maybe there are things that you can go on to stop them being symptomatic, like the pill, the combined pill, the progesterone pill. But if a woman's going to develop fibroids and she lives long enough, she will develop fibroids.
Okay. There's a question about why is it not possible to find an ovary in someone who has not had a hysterectomy?
I take it they've had a scan and the scan has not located their ovary. That's not an uncommon finding. It doesn't mean that there's a problem. It just means that they just need to have more detailed imaging. So perhaps an MRI scan, and that usually would locate where the ovaries are.
Okay. Can I get an endometrioma after menopause?
The simple answer is not for the first time, but if you had an endometrioma during your reproductive years that wasn't treated, it can still cause you problems after the menopause.
Okay. Can a fibroid become cancerous?
There is a very, very small chance of that, but it's very, very small. It's about a 1 in 1,000 chance. So generally, we consider that fibroids are benign tumors.
Okay. Is there a particular thickness of the endometrium you should be worried about?
The endometrium, and this is why we talk about the phases of life of a woman and the phases of the menstrual cycle. The endometrium assumes different levels of thickness at different phases of the menstrual cycle. So you can't just take one figure and extrapolate it to every situation. So we need to know at what time you had the scan, what phase of menstrual cycle you were, how old you were, to be able to give you an answer to that question.
Okay. Are septations and echoes in a cyst dangerous?
Not necessarily. And this is where the nature of the ultrasound, it's important. And there are some other tests that we can do, even when there are septations and cysts within cysts, that sort of thing. So not necessarily. Okay.
And we've had lots of questions about very heavy periods. This is someone who's sent a message to say, my periods are very light. Is that normal?
My answer whenever I get asked that question is that you should be thankful to God that you got light periods. Enjoy your light periods. Most people are desperate to have light periods, but I take your point. What I'll say is that if you're having periods that are lasting less than 1 day, and you're not feeling a pad, then I would say just see a gynecologist. All you might need is just to get examined and get scanned and just to reassure you that everything is fine.
Okay. Well, thank you so much. What I'm going to ask you now is, you've seen from the number of questions we've had and the interaction that this is something that is a very, very common problem, something that generates lots of questions. What advice will you leave people with today? So what are the things that you think, okay, I've given my talk, I've had lots of questions, but I really would want people to just take this away from today?
I think for me, what really breaks my heart is when I see people come to see me after maybe 10 or 15 years of suffering in silence with a problem like this, because they are scared of losing their wombs, they're scared of having a hysterectomy. So what I'll say is, fibroids are very, very common. Endometriosis is common. Any woman who's suffering with significant pain during periods, significant pain in the week leading up to their periods, whose periods are too heavy and are interfering with her work, her life, her social life. Just consider that there's something going on and seek help early. And there are useful treatments available, both medical and surgical, and safe treatments as well that are fertility preserving. So people should not be scared about having surgery because they're worried that they're going to lose their wombs. If you're suffering with such symptoms, then it's best to have surgery that relieves you of those symptoms rather than shying away from having surgery. Because the one thing is, any surgery we do has a greater chance of being safe and effective for you if we do it early enough when the fibroids are not too big and the problem can be managed easier, if you like. The other thing I would say is there are ways women can help themselves. And this is why I started by just trying to explain how a woman's body works. If women educate themselves on how their bodies work, then it becomes easier to understand when things go wrong and when the body is not working as it should. And when that happens, just seek help, go see somebody. And all it might take is just a simple examination and scan, and that can save you a whole life of misery and pain. So if you take nothing else away, take away the fact that there is effective treatment for endometriosis, there's effective treatment for fibroids, and although these conditions cause a lot of pain and a lot of suffering with bleeding and can impact fertility, but they can be treated very, very effectively. And those treatments are readily available. So don't suffer in silence, speak to somebody.
Thank you very much. I would just like to say thank you all for logging on. There is some feedback that we're collecting for our sessions now, because we really want to make sure that they're delivering on what we want them to, which is for you to be understand your conditions better, be empowered to take control about your own health. So please fill in the feedback. I'm now going to hand over to James, who's just going to round up about what the Caribbean Health Network are doing the next week that you can access. Thank you very much.
Well, thank you both. Thank you, Dr. Ngozi, and thank you, Dr. Edi. Really an incredible, presentation, an incredible session, as of all of the Health Hour sessions have been. But just the amount of questions and the amount of information that's been conveyed in the last hour or so is really staggering. So thank you ever so much for the time and the expertise in that. Also, thank you to everybody that's joined on. I can see that there was up to 150 people on our Zoom. We've had people on our Facebook and on our YouTube channel, and that's an amazing thing. We're reaching many people. Of course, it's a great thing that we're able to then record these sessions and make them available via our YouTube channels and our social media channels, including Facebook. So for those people that did ask some of those questions, or maybe didn't catch some of the kind of the answers, or wanted to clarify some of those answers that Dr. Edi gave, please do go to the Can YouTube channel and the Can Facebook page to be able to access that information. If people would like to find out more information on some of the slides that were presented, please drop us an email at health@can.org.uk, and we'll be able to get that to you. I've got some information about March, because March is an incredibly busy week for the Caribbean and African Health Network. We've got many different sessions on. The sessions again run from 11 to approximately 12:15 every Saturday. So just to give you a brief taster of that, in March, on Saturday the 12th, we have our Health Hour session led by Dr. Vanessa on preconception, perineal infections and sexual health. On Saturday the 19th of March, we have a session led by Dr. Patrice Arthur, the causes of pelvic pain in Black women. And the 26th of March, and I'm going to get the pronunciation wrong, so please don't laugh at me, but polycystic ovarian syndrome, and that's Dr. Karen. And again, all of these sessions run on our Zoom channel, but will be broadcast live on Facebook and on YouTube, and they run from 11 to approximately 12:15. For more information on how to join, please visit www.can.org.uk, or if you need more information or would like to pass on information to other people, just get in touch with us and give us a call on 07710 022 384. Next week in particular, I'd like to draw attendees' attention to our flagship International Women's Day event. This event is an incredibly important one that we've put lots of time and effort into. We have some amazing speakers that will be coming along, so please do register your interest. It's around preconception care, miscarriage, and the impact of these events on the mental health of Black women. If you would like to register for that event, which is on Tuesday, the 8th of March, and runs between 10 and 1 o'clock, please drop us an email at events@can.org.uk. Like I say, just to reiterate, that's Tuesday, the 8th of March, International Women's Day event from 10 till 1 o'clock. And to register, please go to please drop a line now to events@can.org.uk. The other final thing that I'd like to mention to everybody and the attendees, that the work that Can does is very broad ranging, and we do cover these health hours to spread the information around health disparities, dispel some of those myths, and talk about some of the effective treatments to help reduce those health disparities for people. But also, we are in the process of raising funds to fund some of that work, in particular our counselling service. We have presently, in the month of March, a crowdfunding campaign that has a target of raising £10,000, that, thanks to our partners at the National Emergencies Trust, will be doubled. So please, if you're thinking or considering or giving in March, please consider Can and the counselling and bereavement service that Can runs as a possible recipient for a gift. The details can be found on the Can website, and I'll also bob them in the chat for you as well. So that's just about it. That's the finally, just to wrap up, I just wanted to say that if anybody wanted any further help or assistance on information, just to please access our support by sending an email to help@can.org.uk, or again, that telephone number, which was 07710 22382. But finally, once again, thank you ever so much, Dr. Edi. Amazing amount of rich information given in the presentation today. Really super enjoyed it. And again, thanks, Dr. Ngozi, for the presentation. But thanks again to all of the participants, those participants that joined us via Zoom, via our Facebook page, live streaming through Facebook, and also on YouTube. Thank you so much. Another amazing session.
Thank you.
Welcome to our Caribbean and African Targeted Health Improvement Program, CATHIP Health Hour. The Caribbean and African Health Network, CAN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating, and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members, and friends. Some weeks will vary and will will include other panel members such as pharmacists, specialist nurses and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell and many more. We have not forgotten to include within our health hours the many societal, cultural, religious and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you and we want you to use the time to listen, learn, share your experiences and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@can.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.